Yakima Valley Community College Radiologic Sciences Program presents Radiographic Positioning, SI joints.
We're going to discuss sacroiliac joints today. Most of the time we refer to those as SI joints. I've set my room up, patients on the table, they're dressed, pajama bottoms in a gown, no underwear, no piercings, the body is free of objects. So let's get right to it. Our X-ray tube is set at 40 inches SID to the Bucky tray. It's a thick body part, film will be in the Bucky tray. I'm transversely centered to the tube. I have collimation, which is 14 by 17 crosswise, because our first projection is an AP pelvis. An SI joint exam consists of an AP pelvis and both obliques. Routines vary from place to place, but that tends to be the most common practice that you will run into. The tube is aligned to the Bucky tray. As you recall from a pelvis exam, we use a 14 by 17 crosswise. ID blocker, if you'll take a look, is towards you is the tech, and I have an R marker in the middle of the cassette, trying to miss pertinent anatomy. Once the tube and the film are lined up, I can push the tray in and then just float my tabletop. Patient's hands either both up or both down. Patient straight on the table, feet uncrossed. Once you get her straight, then you can float the tabletop, and you want the mid-sagittal plane to the center of the film. Use the xiphoid process as a reference point to get the sagittal plane to the center of the film. And then you're going to palpate the iliac crest. Flat hand, firm palpation, finding where the bone ends and soft tissue takes over, and there's her iliac crest. And I want the film's edge 2 inches above that point. When I can see the boundaries of the pelvis, there's the crest, there's her trochanter, her pubic bone, the crosshair. We want that pelvis centered, so you can see that. I'll let you see this relationship here. Pelvis is now centered to the center of this film. Film's edge is 2 inches above, and the film's edge is 2 inches below the pubic bone. I need to focus on her feet now. I need the heels separated and the toes inverted. I've measured my patient, so I know how much mass to use if I'm not photo timing. And then I can give her breathing instructions. Please take in a breath, blow it all out. Don't breathe or don't move. That's your AP pelvis. You want to center the pelvis. You can use the film's edge 2 inches below the iliac crest. You can find the symphysis pubis. Make sure you've got your clearance down there. Remember, women tend to be broad and not as long. Men tend to be narrow and longer. So centering, finding your boundaries and centering the pelvis is a really good idea. If you can't find your boundaries, you can just go with the film's edges 2 inches above the iliac crest. Mid-sagittal plane will be in the center of the film. If you've positioned them in a true AP position without the rotation, you'll have the wings of the ilium symmetrical, the obturator foramen symmetrical in size, and when you invert the feet, you'll bring the greater trochanters out in profile, and the lesser trochanters will be hidden. It's easier to look at an X-ray image, and I want you to see just barely a tip of the lesser trochanters. That will tell you if you did a good job of inverting the feet. That's your AP pelvis. For a sacroiliac joint, we're going to focus just on the joint itself now. We're going to switch the cassette to an 8 by 10. I want the ID block to the top, lengthwise. I'm going to do an RPO. You see this cassette, that's the relationship. I moved the R marker in a ways because I'm going to collimate. My field is going to be right about in here, so I want that marker moved in to a corner. The SI joint will be about this long. if I've done a good job of positioning, the SI joint will be right there. Collimation to approximately that size. Same 40-inch SID, tube transversely centered. Collimation will be 10 inches. Leave your length. And side to side, that's an 8 by 10 film. That's 8 by 10, but that joint space is very narrow. So I'm going to come into about 6 inches, and there's 5 inches. So between 5 and 6 inches, I'd be happy. Okay? If the patient has difficulty holding, you may use a sponge. This is a 45-degree sponge, but we're only going to oblique the patient very shallowly. It's actually 20 to 30 degrees of obliquity. I'm going to have her, I don't want her to move, I want her to move with me, so you're going to have her elevate her arm, cross it over the chest, just bend the right knee, and then roll your patient like a log. You can keep them from scrunching up on you that way. Just have them roll up like a log. She's actually more than a shallow oblique, so she'd come down. If you need a sponge, you can't push the sponge in all the way because that will make her more to 45. You can back the sponge out and still use it as a stabilizer, but it's a very shallow oblique. This knee is barely bent, resting on the other leg for stability. Make sure she's straight on the table. Okay. Okay. Again, 20 to 30 degree obliquity. I put a right marker on here. I'm doing an LPO. That's because you are going to demonstrate the upside. The R marker that we used indicates we're after the right side. But to demonstrate the right side, you must do an LPO. Part film reference point is you find the ASIS. And I want to caution you, when you palpate for the ASIS, come in from the patient's tummy side. Watch my hand here. Okay? I'm going to come in flat-handed. I'm going to warn them they're going to be feeling some bony landmarks on their pelvis bone. Come in flat-handed from the tummy side. And you're going to feel for the most prominent point that sticks out anteriorly. If I came in from the side here, I can feel that ridge here. I can actually feel it very well there. Okay? But the peak of the mountain, see, I'm finding the parts of the mountain here. The peak of the mountain, the very most prominent part, is from the tummy side. That's my reference mark. So don't feel from the side or you won't have it centered. Make sure you come in from the tummy side. And I want to be 1 inch medial to that mark. And I want to be level with that mark. Can the camera see that angle there? I'll do the other oblique and you can see what I'm talking about too. But here's the ASIS. This crosshair is coming right level with it to the center of the film, exiting to the film. And I'm 1 inch medial to that shallow oblique. Okay? You can put your cassette in. You're going to use approximately 30% more mass on this projection than you did on the AP. And the same breathing instructions. Take in a breath, blow it out, don't breathe or don't move. Let's do the other oblique, Dre, because then I can think they can see that centering a little better. Very shallow oblique, 20 to 30 degrees. This arm up and out of the way, but not over her face. That's not comfortable for the patient. Patient straight on the table. Come in from the tummy side to find the ASIS, flat-handed, and I'm going to feel the peak right there. And I'm going to be 1 inch medial to that point and level with that point. And I think the camera can see this angle much better. Now, if I'm doing an RPO, think about what I said a few minutes ago. You're demonstrating the upside. You need to change cassettes, and you need to use an L marker. I'm collimating, so I moved the marker in a ways. Can you see that? And I'm using an L marker because I am demonstrating the left SI joint. Again, ASIS, right there, 1 inch medial at the level. Shallow oblique, 20 to 30 degrees. If you've done a good job of positioning, you will demonstrate this joint space open. It's hard to demonstrate the entire joint space open, but at least 75% of it will be opened with the patient in a 20 to 30 degree obliquity, demonstrating the side away from the film. Andrea, can you add anything to this discussion? Okay. Let's talk about shielding. The AP pelvis on a female, we've talked in previous lessons, you really can't shield on a female patient unless you have a shadow shield. Male patients, you could use a scrotal cup. You could use a strip down here, like that, on a male patient, covering up the scrotum. SI joints, you can't protect both ovaries, but you could, if you can get the shield to lay there, you could protect that ovary. I didn't show you on the first one because you wouldn't be able to see that lead strip, but that's what you could do to protect one half and curve it into the scrotum if you needed to. Okay? And the patient, it's not going to stay, but the patient can help you hold it there. Okay? We're done with today's lesson. Thank you.